regingival graft, soft tissue augmentation, to change the texture, the thickness of that tissue for long-term health. And there are enough evidence-based reports that show that this does make a difference, and it makes it easier to maintain health long-term. When you are looking at an anterior aesthetic zone soft tissue problem, assessing it is very important, and you want to make sure that you have a good understanding of what the underlying bone architecture is. Now, if you compare the two cases you see right here, the case on the left, which seems to have good intact soft tissue, which you have achieved with good socket preservation, and it has good underlying bone, is more or less a slam dunk case for an implant because there already is enough bone, there's already enough soft tissue. On the right side, however, is a very complex case because there's already a soft tissue deficit. There is obviously an underlying bone deficit. The tooth spacing is more. So whatever you end up restoring there is going to be a prosthetic challenge as well. So all of these things matter, and they need to be factored in when you start planning your procedure. Also, when you do an extraction of a tooth, anticipating the bone defect is very important from point of view of planning your soft tissue management. So if the bone defect is, let's say like this, and how do you anticipate it is with a probe. Once you extract the tooth, just take your perio probe, go towards the facial plate and try and see where the facial plate is missing. Based on how narrow or how wide that facial plate defect is in terms of that dehiscence defect, you will change your incision design. So if the defect is narrower, you could do basically a papilla sparing incision, which means you're not touching the papilla at all. However, if you are not able to diagnose the defect properly, the bone defect properly, and you end up doing a papilla sparing incision, you will actually be in further trouble because where your incision lines end will be where your defect ends. And that means that you will actually never be able to get complete closure. So never ever do that. You have to make sure that you diagnose the defect properly. So that if the defect ends up being larger, you will have to move the incision lines to the next line angles. So if you see where the yellow lines are here, the incision lines, I have done the same kind of hockey stick incision, which does not end up with a sharp angle. And it's moved to one tooth, one line angle distal to where the site is, because where your defect ends should be about 2 millimeters away from where your soft tissue reflection is. One other thing I just want to share with you really quickly is a recent algorithm which we published in the AAID journal, Journal of Oral Implantology. I call this the SRA, Sequential Ridge Augmentation Decision Tree. This will help clinicians in understanding and deciding what sequence of augmentation you should do. If you have a defect like this, whether you should do soft tissue augmentation first or hard tissue augmentation first. This is a good algorithm to help you decide that. So I'll just share one quick case with you for you to understand why it is important. Now this, for example, is a photograph of a case that was referred to me. Obviously, the soft tissue was not looked at all by the implantologist who placed these implants. And as a consequence, you have a tremendous soft tissue defect, no keratinized tissue, you have a frenal pull, you have all kinds of problems. So you want to avoid getting into a situation like this. So which is why the next slide is important. We want to make sure that we have enough soft tissue, connective tissue available to us. And that connective tissue, whether we're taking a graft, for example, needs to be mainly connective tissue and less adipose tissue. Adipose tissue is the yellow tissue that you see, and adipose tissue tends to shrink. So you want to have the major bulk of your tissue, your connective tissue graft, to be connective tissue. So applying the SRA protocol, the Sequential Ridge Augmentation protocol that you see here, we want to assess this defect first. You want to assess whether there is, first thing to assess is whether there is enough keratinized tissue. In this case, there is borderline keratinized tissue, which means you have about 2 millimeters of keratinized tissue. That is enough for reflection for any GBR procedure. What is the concept here? The concept is that when you reflect the flap, you should have at least 1 millimeter of keratinized tissue on either side of the flap, so that your suturing of the GBR procedure becomes easy. So in this case, you know that you have adequate, so you can move to, you need minor soft tissue correction, then you can do implant placement, and you can do major soft tissue correction later in case it's required. So this is how the sequence of this case was. The implants were placed, subsequently a free gingival graft was done, and this is what the final result showed with enough keratinized tissue, enough thickness. So this is a fairly simple case, right? So this is what we normally do. The SRA protocol is very important for the next case. Next case where you have often inadequate keratinized tissue to begin with. So what is the crux of the SRA protocol? Is that the SRA protocol tells you to diagnose how much keratinized tissue there is in that edentulous site before you start thinking of GBR, before you start thinking of any other procedure. Because if you have inadequate keratinized tissue, the SRA protocol states that you should actually be doing soft tissue augmentation first, then waiting for about 2 months, and then doing your hard tissue augmentation if major hard tissue augmentation uh, needs to be done. So if you have a substantial bone defect horizontally or vertically, and you have very, very less keratinized tissue, you are safer off doing addition of keratinized tissue, soft tissue graft first, waiting for 2 months, and then doing your GBR. So I'll just demonstrate in this particular case what we have done. This is an edentulous site, as you can see. There is not enough keratinized tissue. So we have gone in, done a free gingival graft to increase the band of zone of keratinized tissue. Subsequently, 2 months later, we have done GBR. Subsequent to that, we have placed implants, and ultimately you end up with a very, very nice soft tissue profile, a very thick keratinized tissue with good bone structure underneath around the 2 implants. And by doing this, you know from evidence that you are safer long-term in terms of stability and retention of these 2 implants. So what does the SRA protocol do? It basically preferentially assesses soft tissue deficiency before hard tissue deficiency. Keep in mind, again, I mentioned this to you in the beginning of the lecture, this is not something that is invented by me. I have put together evidence and I have published this, so this is evidence-based. So this is why it's more important to follow. This may increase predictability of hard tissue augmentation, especially in cases where major bone deficits exist. And it also identifies cases where soft tissue grafting should be done before hard tissue grafting is done. Soft tissue grafting also has a relevance to GBR because sometimes if your soft tissue management is not correct, then the wound tends to open up. You can have major catastrophes where you have opening of the wound, infection of the graft inside. So it's very important to consider all the points which I've mentioned so far: incision design, keratinized tissue, SRA protocol, to try and avoid issues like this. Just to share something else with you, we are in the midst of doing a couple of research assessments for fibroblasts to see how they react to biomaterials and to see how we can minimize chances of exposure. But that's just something on the side. You as a clinician need to understand that you need to minimize risk of exposure by handling tissue in a certain way. Talking about soft tissue, one other point I want to mention is you need to be sure that you are assessing soft tissue not just from the front, but from the side as well. If you see this particular tooth, you will know that the tooth, in addition to having recession on the tooth is also positioned more buccally. Now, imagine this to be an implant. If this was an implant, a dental implant, and you're looking at it only from the front, you would maybe not understand that the implant is positioned buccal, which means that it is more difficult to address, more difficult to treat, because as the implant or the tooth becomes more and more buccal, more out of the buccal housing, for the fibroblast to go around that tooth to form new soft tissue is even harder because the circumference increases. So always make sure that you try and assess existing soft tissue from a 3-dimensional perspective. The most common site from where we take soft tissue is the palate, and the palatal harvest is something which we have also researched, and we have gone through various protocols to see which one works best in my hands. I will share with you something called as the CPH technique, the controlled palatal harvest technique, which I again have published recently. and I'll share with you a video as to how that is done. I think that makes it much easier and more predictable to harvest soft tissue compared to what we used to do before. So this is the video which shows us going to the palate. And what we are doing is we are doing one simple incision, which is an L-shaped incision with a vertical anterior release. And we are harvesting the soft tissue graft from the flap side, not from the bone side. Now, by harvesting it from the flap side, you are able to visualize the thickness of the graft that you're taking. And that makes it much better, much easier for you to handle it. However, keep in mind that this is a little technique sensitive, and there is a possibility of you perforating the flap if your blade angle is wrong. So if you're just starting off with connective tissue grafts, I would suggest you stick to the old conventional way of harvesting it from the bone side. But if you're a little bit further advanced in this, then the CPH technique is something for you, which will give you better control over the thickness of the graft that you're harvesting. Because one of the reasons for failure for soft tissue graft is either the graft is too thin or too thick. So you need to be able to control the thickness quite well. And optimum thickness is typically in the range of 1.5 to 2 millimeters thick. So just we need to keep that at the back of our mind. One other thing I want to stress on is a lot of times the results that we see cannot be achieved unless the armamentarium is correct. The armamentarium that I routinely use for cases like this is a Castro Evo needle holder, corn pliers. I always work under loops. My loops are 2.5x TTL loops. The reason I don't